Welcome to the deep dive. Today, we're tackling a really important topic, especially if you're uh, gearing up for the MSRA, primary open-angle glaucoma, POAG.
That's right.
Think of this as, getting straight to the core stuff you need, the high-yield knowledge.
Exactly. We've tried to boil it down.
Yeah.
So glaucoma, in general terms, it's a group of conditions, isn't it? They damage the optic nerve. Often it's linked to raised pressure inside the IOP.
Right, intraocular pressure.
Yeah. And this pressure harms the retinal ganglion cells, the nerve cells sending signals to the brain, and their pathways, the axons. There are different kinds: primary, secondary, open angle, closed angle.
But today, it's all about primary open-angle glaucoma, POAG.
Precisely, POAG.
So what are the defining features? What makes it POA?
Okay, so POA is chronic, it's progressive, usually starts in adults. Key things: IOP often over 21 millimeter Hg, but crucially, the drainage angle in the eye is open.
Unlike angle closure glaucoma.
Exactly, but even with that open angle, you get optic nerve damage, vision loss, typically starting out in the periphery, and it usually affects both eyes, though maybe not equally. The problem is resistance to the fluid, the aqueous humor getting out.
Got it. So our mission today is really to lock this down for your MSRA revision. We'll cover the definition, causes, risks, how it happens, what else it could be.
How common it is, symptoms, signs, tests, management, the outlook, complications.
And we'll throw in some memory aids along the way.
Definitely. Let's start with that definition again. POA, chronic optic nerve damage, vision loss, linked to that increased IOP and poor drainage.
And that open angle part is key, you said. It's not like a blocked drain cover.
No, not a physical blockage like that. Think of a kitchen sink. The drain itself looks clear, wide open,
Okay.
but maybe the pipes further down are getting a bit clogged, slowing things down. So the water level, the pressure slowly rises. That's sort of like POA. The angle's open, but the trabecular meshwork, the eye's filter system, isn't letting fluid out efficiently.
That's a good analogy. The slowly clogging drain in an open sink.
Exactly. Pressure creeps up over time.
So why does it start clogging? What's the actual cause, the etiology?
Well, the tricky thing is we don't know the exact single cause. It's almost certainly multifactorial.
Ah, okay. So multiple factors involved.
Yes. We think genetics play a part. Some people are just more predisposed. Age is definitely a factor. Things change as we get older. And then there are likely structural issues, abnormalities, maybe just wear and tear in the trabecular meshwork itself that hinders the outflow.
So like inheriting a slightly dodgy drain that gets worse with age.
Kind of, yeah. And the genetic link is quite strong. If your parent, sibling, or child has glaucoma, your risk is significantly higher, around 16% chance.
16%? Wow. That's quite high.
It is.
Is there a quick way to remember those potential causes?
Maybe think. Age-related genetic trabecular issue hits the main points.
Age-related genetic trabecular issue. Okay, so who's most at risk? Let's talk risk factors.
Right. Well, advanced age is a big one. We mentioned family history. Ethnicity is also really important. People of African, Hispanic, or Asian descent have a higher risk.
Higher prevalence, yeah.
Definitely. Then, elevated IOP itself is a major risk factor. Even if it's technically normal for some people, higher is riskier. Being short-sighted, myopia increases risk too.
Oh, interesting. Myopia, too.
Yes. And something less obvious, maybe the thickness of your cornea. A thinner central cornea is a known risk factor.
Right, CCT.
Exactly, central corneal thickness. And finally, having conditions like diabetes or hypertension also seems to increase the risk somewhat.
You mentioned age being a big factor in the UK. What were those figures again?
Yeah, in the UK, it's about 2% of people over 40, but that jumps quite a bit to around 10% for those over 70.
10% over 70. That's really significant.
It is, and it highlights why screening is important as people get older.
Absolutely. And remembering those ethnic variations is crucial for clinical practice.
Definitely, for assessing risk.
Okay, a mnemonic for the risk factors. You had one for etiology.
Let's try. A fat heat.
A fat heat. Okay, break it down.
A for advanced age, F for family history, A for African, Asian, Hispanic ethnicity, T for thin cornea, H for high IOP, E for eye conditions like myopia, and AT for associated things like diabetes, hypertension.
A fat heat covers the key ones. Great. Now let's dive into how this actually causes damage. the pathophysiology.
Okay, so it starts with that trabecular meshwork becoming less efficient, resistance to outflow goes up,
All right.
so aqueous humor builds up, IOP increases. This higher pressure then directly damages the optic nerve fibers, puts mechanical stress on them.
And that damage is what causes the vision loss.
Precisely. The retinal ganglion cells in their axons get damaged or die off, and because it often starts affecting the peripheral nerve fibers first, the vision loss typically begins at the edges of your sight.
Which people might not notice initially.
Exactly. It's very gradual, very insidious. It can progress towards the center over years, potentially leading to tunnel vision and, if untreated, blindness.
So it's a slow, silent process, often.
Very much so. And it's not just the direct pressure. Other factors like pressure on the optic nerve head itself, where the nerve leaves the eye, and maybe reduced blood flow to the nerve, the microvasculature, likely contribute too.
And what about normal tension glaucoma, where the pressure isn't high?
Ah, yes, NTG. That's where you see the same kind of optic nerve damage and vision loss, but the IOP measurements are consistently within the normal range. The exact mechanisms there are still being researched, but it suggests some optic nerves are just more vulnerable, perhaps to even normal levels of pressure or other factors like blood flow.
Okay. Can we get a quick summary for the pathophysiology?
How about trabecular trouble, pressure up, nerve down, vision out?
Trabecular trouble, pressure up, nerve down, vision out. Nice and clear sequence. Okay, so if we suspect POAG, what else should be on our minds? The differential diagnosis.
Good question. You need to rule out other things. Of course, other types of glaucoma, especially angle closure where the angle is physically blocked.
Right, need to just check the angle.
Absolutely. Then other conditions that affect the optic nerve directly, maybe inflammation or ischemic conditions, that could look similar. And finally, secondary causes of glaucoma where something specific is raising the pressure, like steroid medication use, previous eye trauma, or other eye diseases.
So a really thorough eye exam is vital to pin it down.
Essential. Plus those specific tests we'll talk about.
And just to confirm, the scale in the UK, POG, is the most common type.
By far. Accounts for about 90% of all glaucoma cases in the UK.
90%. And the prevalence, 2% over 40, 10% over 70.
That's right. And roughly equal numbers of men and women affected.
Okay. Clinical features. What does the patient experience and what do we see?
Well, the big challenge, as we've said, is that early on, there are usually no symptoms. It's asymptomatic.
The silent thief of sight, as they say.
Exactly. When symptoms do start, it's typically that slow loss of peripheral vision. People might eventually notice bumping into things or missing things to the side. It can progress to tunnel vision. Some might find it harder to adapt to dim lighting. Only in quite advanced stages does central vision, visual acuity tend to decrease.
And what signs are we looking for as clinicians?
We might detect that slowly rising IOP, often picked up incidentally during a routine check. Goldman tonometry might show a pressure over 24 mmHg. Crucially, we look for characteristic visual field defects on testing, like arcuate scotomas. And then there's the appearance of the optic disc. We look for pathological cupping.
Cupping.
Yeah, the central depression in the optic nerve head, the cup, gets larger relative to the whole disc as nerve fibers are lost. An increased cup-to-disc ratio.
So how does a case typically get picked up then if it's often asymptomatic?
Often by an optometrist during a routine sight test. They might see that suspicious cupping on slit lamp examination, or the visual field test flags up a defect, or the IOP is measured at 24 mmHg or higher. Any of those would trigger referral.
And what's involved in the full workup? The comprehensive examination.
It involves several key things. Central visual field testing, that's usually standard automated perimetry. A detailed look at the optic nerve and fundus. Accurate IOP measurement, ideally with Goldman applanation tonometry.
The gold standard.
Yes. Gonioscopy, using a special lens to directly view the drainage angle and confirm it's open. And pachymetry to measure the central corneal thickness.
Right, because that affects IOP readings and risk assessment. Okay, let's focus on those investigations.
Yeah, so the main ones are tonometry for IOP, optic nerve assessment looking directly or using imaging like OCT.
Optical coherence tomography.
Exactly. Visual field testing, perimetry, gonioscopy to check the angle, and pachymetry for CCT. Those are the cornerstones.
And the pathways, usually Optum flags it, refers via GP, then ophthalmologist confirms.
That's the typical route, yes. The optometrist raises suspicion, makes a provisional diagnosis, and refers. The ophthalmologist then uses these investigations to make the final diagnosis and, importantly, assesses the individual's overall risk of future vision loss, considering their IOP, CCT, family history, age, life expectancy, etc.
How is the severity graded?
We usually talk about mild, moderate, severe, and end stage. Mild might just be early field defects. Moderate involves more significant defects like an arcuate scotoma and visible thinning of the nerve rim. Severe means extensive field loss, marked thinning. And end stage is, sadly, minimal remaining vision and very little healthy nerve tissue left.
And the NICE referral criteria. When must an optometrist refer?
NICE is refer if there's optic nerve head damage suggesting glaucoma, or a visual field defect consistent with glaucoma, or if the IOP is 24 millimilli G or higher on Goldman tonometry.
You mentioned OCT being really useful. Why specifically?
OCT is fantastic because it gives objective quantitative measurements. It can measure the cup-to-disc ratio very precisely, but even more importantly, it measures the thickness of the retinal nerve fiber layer around the optic nerve.
Ah, so direct measurement of the nerve tissue.
Yes, exactly. And we can store these scans and compare them over time. It allows us to detect very subtle changes, progression, sometimes even before it shows up on a visual field test. It's brilliant for monitoring.
Okay, so diagnosis made.
Yeah.
POAG confirmed. What's the plan? How do we manage it?
The absolute main goal is to lower the IOP, get it down to a level where further nerve damage is slowed or stopped altogether.
And the main tools are?
Three mainstays: medications, mostly eye drops, laser therapy, and surgical procedures.
What does NICE generally recommend starting with?
For newly diagnosed POAG, NICE usually suggests starting with prostaglandin analog eye drops PGAs. They are generally very effective and used once daily.
Like a latanoprost.
Exactly. Latanoprost, travoprost, bimetoprost. If those aren't enough, or the patient has side effects, then second-line options include beta blockers, carbonic anhydrase inhibitors, or sympathomimetics. Often people end up needing more than one type of drop.
And laser, SLT.
Yes, selective laser trabeculoplasty, SLT. It's increasingly used earlier, sometimes even as a first-line option alongside drops or instead of drops, especially for people who might struggle with compliance. And surgery, like trabeculectomy, is usually for more advanced cases or when drops and lasers aren't working well enough.
And regular checks are crucial, presumably.
Absolutely essential. You need to monitor the IOP, the optic nerve appearance, and the visual fields regularly to see if the treatment is working and adjust it as needed.
Can we quickly recap how the different drop types work?
Sure. PGAs mainly increase fluid outflow through the uvea-scleral pathway, a secondary route. Beta blockers reduce the eye's fluid production. Sympathomimetics can do both reduce production and increase outflow. Carbonic anhydrase inhibitors also reduce production. And the older ones, miotics like pilocarpine, increase outflow by constricting the pupil, but they have more side effects, so are used less now.
Okay. And the laser and surgery options. SLT, you mentioned, stimulates the meshwork. What about trabeculectomy?
Trabeculectomy creates a new drainage channel, a sort of controlled leak for the fluid to bypass the blocked meshwork. It forms a little blister or bleb under the conjunctiva. There are also artificial shunts or tubes that can be implanted to drain fluid.
And newer techniques, MIGS.
Yes, minimally invasive glaucoma surgery, or MIGS. Things like tiny stents placed in the trabecular meshwork or procedures to open up Slem's canal, the eye's natural drainage channel. They aim to be safer than traditional surgery, but maybe slightly less potent at lowering pressure. Good options for certain patients.
And driving. We should touch on that again.
Yes, very important. Patients must inform the DVLA. Glaucoma, especially if it affects the visual field, can impact fitness to drive. They'll likely need a specific visual field test arranged by the DVLA.
Patient education sounds absolutely critical throughout this.
Couldn't be more critical. Patients need to understand it's a lifelong condition usually. They need to know why they're taking drops, how to put them in correctly, the importance of sticking with it even if they don't feel any different, and potential side effects. Compliance is a huge factor in success.
What if it's just high pressure found? Ocular hypertension, but no nerve damage yet.
Good point. For ocular hypertension, IOP of 24 or more but no damage, NICE suggests offering 360-degree SLT as a primary option, or, alternatively, PGA or beta blocker drops. The aim is to reduce the risk of developing actual glaucoma.
And if treatment isn't working well enough for ocular hypertension?
You'd consider switching drops, maybe adding a second agent if needed. Often requires combination therapy.
What about the other way around? Suspected glaucoma changes, but the pressure is always below 24.
Like normal tension glaucoma suspects. In those cases, treatment might not be offered immediately unless they are clearly progressing or considered at high risk of significant vision loss over their lifetime based on other factors. It's a careful judgment call.
And surgery might come in earlier for advanced cases?
Yes, if the glaucoma is severe or progressing rapidly despite medical or laser treatment, then surgery, perhaps with agents to stop scarring like mitomycin C, might be offered sooner.
So always monitoring, always tailoring.
Precisely. Regular follow-up, adjusting treatment based on IOP, nerve appearance on OCT, and visual fields, and keep reminding patients about the DVLA.
Okay, time for that drug class mnemonic again.
Right. Prostaglandins, pump out fluid, beta block production, sympathomimetics, squeeze and send, carbonic arrest creation, miotics, make muscles move.
Got it. What's the overall outlook? The prognosis?
Generally, it's actually quite good if it's caught early and managed properly. The treatments we have are effective at slowing progression for most people.
But the flip side?
The flip side is that if it's missed or not treated adequately or the patient doesn't adhere to treatment, then yes, progressive, irreversible vision loss, potentially leading to blindness, is the natural course. So monitoring and adherence are key.
Which brings us back to prevention and screening, given how silent it is early on.
Absolutely. Because you can't prevent the underlying changes, the focus is on early detection through screening to allow timely treatment.
What are the general recommendations?
For people without a family history, it's usually opportunistic screening via routine eye tests, maybe every 2 years. Annual screening is often advised from age 65. But for those with a first-degree relative, parents, sibling, child with glaucoma, screening needs to start earlier and be more frequent.
Oh, really?
Generally advised to start checks at age 40, every 2 years until 50, then yearly after that.
Okay. And just to clarify, laser peripheral iridotomy, that's for angle closure, not POAG prevention.
Correct. LPI prevents angle closure by making a hole in the iris. It doesn't help with the trabecular meshwork dysfunction in POA.
Right. Finally, complications.
The main complication of POA itself is, of course, the progressive vision loss and potential blindness if it's uncontrolled. That impacts quality of life hugely.
And complications of treatment.
Yes, medications can have side effects, local ones like stinging or redness, or sometimes systemic effects, especially with beta blockers. Laser and surgery carry risks too, like inflammation, temporary pressure spikes, infection, or hypotomy pressure going too low. But overall, the benefits of treatment usually far outweigh these risks, especially with careful monitoring.
So wrapping up, the big takeaway is POAG is serious, it's common, often silent early on, but definitely manageable with early detection and consistent treatment.
Yeah.
Understanding this is vital for the MSRA.
Absolutely. It's a core topic. And, thinking about that silent progression, it really makes you ponder. How can our healthcare systems get better at implementing truly effective screening programs? How do we catch more cases earlier before irreversible damage occurs, especially on a population level?
That's a really important question for the future. Definitely food for thought.
Yeah.
Okay, that brings us to the end of this deep dive. Remember, for your MSRA prep, do check out passthemsra.com and our free resources at freemsra.com.
Great resources.
Thanks for joining us.